Welcome. It's my pleasure as Editor-in-Chief of Catheterization and Cardiovascular Intervention to welcome Richard Ringel to talk about the research that they have recently published and been featured as an editor's choice, the acute outcome of stent therapy for coarctation of the aorta, results of the coarctation of the aorta stent trial, or COAST trial. Richard joins us from Tausig Heart Center at Bloomberg's Children's Hospital in Baltimore. And Richard, I want to welcome you and congratulate you on this research. I think it's a phenomenal area. We have a lot of questions about how best to treat this. And what I'd like to do is to talk just a little bit about that patient population that you had. Maybe you can help us understand who you did look at, who you didn't look at, and what you have taken away in terms of the findings.
Sure. Well, first, thank you very much for giving me this opportunity to speak. It's very nice to have a congenital heart disease type of research project highlighted in the journal. Obviously, this journal is important to us in congenital heart disease because I think most of our work is published in this CCI journal. Regarding the trial, I admit that stenting of aortic coarctation has been going on a long time, but there have not been any real clinical trials. There are no FDA-approved stents available in the United States for this indication. We have biliary stents, stainless steel biliary stents that we've been using for many years that get up to the adequate sizes for the aorta, but we don't have any stents that have been specifically designed for this purpose. And because of that, there really haven't been any trials. So we set out to do a trial with the Cheatham Platinum stent, which is a stent that has some advantages perhaps in its radio opacity, in the rounded edges at either end, and in its ability to expand to a large diameter, 22, 23 millimeters in diameter. So that's the stent that we chose. That's the vehicle, but honestly, it's a test of the concept that's been going on for many years, stenting of aortic coarctation. So you asked about the patient population. Patient population includes teenagers and adults, anyone over 35 kilos. We chose 35 kilos because we knew that this was going to be a long-term study for FDA approval. Initial outcomes at 1 and 2 years, but ongoing follow-up for 5 years. And if we were extending this down into the very small children, it would be difficult to tease out failure of the stent therapy versus growth, because we know children grow and that the stents need to be further enlarged for them. So we start at 35 kilos. You get to be about 90% of the aortic size at that age, and we hope that there won't be too many confounding cases of patients outgrowing the stents. So you asked about the population. That's the first issue of the population.
Yeah. Now I noticed that these were primary de novos, that you didn't do post-surgical coarctations. And
no, it's about, I'm sorry, it was about half and half. Okay. Natives, in almost every trial I've read, every small case series and so forth, it has stood up for years, about 60-40, 60% natives, 40% recoarctation. So yes, both were included in this trial.
Good. Very tight lesions, I think, were excluded.
Yes, so what we call near-atretic lesions were excluded. There is a feeling in the community that near-atretic lesions are better served with covered stents because of the obvious risk of creating a tear if you're expanding an area to more than 4 times its native size. So for the typical near adult or adult patient, if you're starting at 3 millimeters or less and you expand to 4 times its size, you're only getting to 12 millimeters in diameter. While that may be acceptable in stage therapy, it's difficult in a trial to then prove that you were successful. So again, we chose 3 millimeters as the minimum. Anything below that would then either be done off-label with the standard stents or with covered stents in a separate trial that we have going, the COAST 2 trial, the covered stent trial.
And so from this procedure, it clearly was safe in the hands of experts such as yourself and others. And you might comment a little bit about that in terms of your concerns about the tissue. So for non-pediatric interventionalists, non-structural individuals, they may not be aware of the concern about tissue and how the tissue may respond differently. But I think you clearly showed that this was safe in that population.
Yes, thank you for that lead-in. We do have concerns about how much you can expand a stenotic lesion and the risk that there may be tears that develop either acutely or late. We have recognized that there is an incidence of aneurysm or pseudoaneurysm formation after a stent procedure, and it seems as if that number is approximately 5% after 1 or 2 years. So we chose to use a predilation protocol that would test the ability of the tissue to expand, both to rule out acute rupture and also to rule out non-compliant aortas that may develop tears later on. So we used this predilation protocol. And for better or for worse, we did have a few patients, I think it was 5 patients, who developed small outpouchings at the time of the predilation. Now, many colleagues around the country feel that if you just go ahead with the stent, you might avoid those small outpouchings. My personal feeling is that it's better to know about them up front, because then those patients can receive a covered stent. You can close off any potential areas of weakness. So I think it's a good thing to know. So we, in the trial, do believe in the pre-stenting and use that. And as I said, there were a few patients who did develop some what looked like irregularities. You could call them small aneurysms. They were very small, and they were shunted out to the covered stent trial. The other patients who received the stent, there were very few patients who had any acute problems. As you indicated, it looks to be a pretty safe procedure, which again confirms what has been reported by many groups around the country and around the world in the past.
So as you point out, this is the largest series. It's certainly well constructed. It provides a framework. What do you think the takeaway for individuals that are interested in doing this or learning about it is going to be? How is this really going to impact practice outside of your own practice?
Well, the takeaway, as I think you indicated, is that this is acutely safe. And we are not satisfied with showing acute safety, and we need to, in this day and age, not only assure that you can do the procedure and do it safely and get a good result, because as you indicated, we eliminated the pressure gradient around the arch almost entirely on the acute basis, but we need to know what the follow-up is. And this is the acute paper. I hope to be submitting the follow-up paper to the journal in not too distant future. There have been many one-year follow-ups or some one-year follow-ups. We think the 2-year follow-up is more important, so we've waited and going to have the 2-year data so that we can present it in a more confident manner. And right now I can say that the data is looking quite good for long-lasting improvement, not just short-term improvement.
One of the questions that people are going to ask, I think, is are there going to be risks of fracture, re-narrowing, perforation, and not to have you give away information that you have, but in your experience, are those founded concerns, or are those just the theoretic concerns that we face anytime we do big vessels with large stents?
I think those are all very valid concerns, and let me see if I can address them one at a time. We'll talk first about restenosis or in-stent restenosis. That seems to be infrequent, but there are definitely patients who develop very exuberant intimal proliferation with obstruction in the stent. We have a few cases of that, very few I'd like to say. I believe in the COAST trial I can only think of 2, and both of those patients did go back to the cath lab and receive covered stent therapy in the hopes that the covering would prevent the intimal ingrowth. So yes, that definitely can be a cause for restenosis. We do have a few patients who went back to the cath lab for planned redilation because of growth. They were at the lower end of our age and size range. But otherwise, we do not see much in the way of restenosis. Most of the patients, the vast majority of patients, have pressure differences between upper and lower extremities, even at 1 and 2 years, that is under 15 to 20 millimeters mercury without upper extremity hypertension. So, so far the preliminary on the late follow-up is that it looks quite good. The stent fracture issue, which was your third question, not wanted to cut you off, but that was your third question, I think is very important. We do know that stents fracture in a variety of locations around the body, and there have been stent fractures recognized on the stainless steel stents in the aorta. Somewhat surprisingly, the Europeans who've been using these stents, these CP stents, the Cheatham Platinum stents from NewMed for many years, they've not reported hardly any fractures. But I can tell you that we are seeing fractures in the 1 and 2 year follow-up, and that's one of the reasons why we're extending our follow-up to 2 years before reporting it. So far, we have not had any patients who've needed a return to the OR, return to the cath lab, or who have had any aneurysms or pseudoaneurysms associated with fractures. So far in our follow-up, the fractures appear to be incidental and not causing patient concern. But we are following that up very closely. We don't just follow the patients clinically, we follow them with fluoroscopy, biplane fluoroscopy at 1, 2, 4, and 5 years to check on stent fractures, and then of course also check to see if there's any clinical problems that are associated with the stent fractures.
Well, it's great to have the acute results and to know that you're getting such a good response in that patient population. As you say, I think the real proof of this is going to be in that 2 year plus follow-up and showing exactly how the patients do in a very organized and structured fashion. I'm excited to see that. I know that that's the kind of information that at the annual SCAI meeting certainly is going to have a platform, and I would hope that you'd consider CCI when that date is there as well, because it's great. It's an important area. We don't have good therapy yet for it, and I think this gives us that option really to define how we ought to be treating patients. So thanks for joining. I know you've had a very busy day, and I think that our readers and our listeners are going to take away a lot from this, Richard. Thanks.
Thank you very much.